Hello everyone. Thank you very much for this kind introduction. I am from the Department of Respiratory Medicine, name, hospital. In Japan, I would like to express my gratitude to the President of the Society, the Chair, and all the participants and audience members who have given me this opportunity to present. I am honored to be here today. Today's topic is the selection and monitoring of immunosuppression for interstitial lung diseases. I will begin now. In today's agenda, we will discuss the classification of interstitial pneumonia, the mechanisms of the underlying disease, and the cytokine pathways that cause fibrosis, followed by a discussion on immunosuppressive drugs for interstitial pneumonia with progressive fibrosis and their and characteristics of each drug. Let's move on to the classification of interstitial pneumonia. Interstitial pneumonia is broadly classified into idiopathic, autoimmune-related, environmental-related, drug-induced types, and other forms of ILD. Among these, immunosuppressive drugs are used in some cases of idiopathic pneumonia and NSIP. NSIP and COP, SO and immune-mediated interstitial pneumonia, SSD, raw ILD, PMDM, ILD, SLE, IP, and also HP, so the other causes. Drug-induced, and let's look at the imaging and pathological patterns for which drugs are indicated. The UIP pattern is a condition primarily characterized by fibrosis, and immunosuppressive drugs are not often indicated. NSIP and OP are conditions primarily characterized by inflammation and immune-mediated causes, so immunosuppressive drugs are expected to be effective. It is important to know that different etiologies can lead to various types of radiological and pathological patterns of interstitial pneumonia. Evaluation and diagnosis from multiple perspectives are necessary. Let's move to the etiology of pulmonary fibrosis. So, various inflammatory processes are known to lead to fibrosis in the development of interstitial pneumonia. It is known that pro-fibrotic environments and cytokines, as well as their downstream pathways, are associated with this process. Through these pathways, it is said that sustained activation of fibroblasts occurs. Fibroblasts occur, so and leading to differentiation into myofibroblasts and progression of fibrosis. There are two main cytokine pathways that cause fibrosis. The first one is the pro-inflammatory process, stimulus IL-6, IL-6, TNF. So, and this kind of cytokine associated with TGF-beta and its main pathway is involved in interstitial pneumonia, activating fibroblasts. So, the second is the type 2 cytokine pathway, which is involved in fibrosis following tissue damage and allergy. So, the immunosuppressive drug target is the pro-inflammatory pathway downstream. So, that's associated with TGF-beta. This is a diagram of progressive fibrosing interstitial lung disease, abbreviated as phosphorus monofluoride ILD. The red outlined areas indicate conditions where inflammation is suspected to be associated with fibrosis, including idiopathic NSIP, OP, and IPAF, and vascular rheumatoid arthritis. SPMDM, MCD, SSC, and others of ILD, and in hypersensitivity pneumonia is also indicated. Inflammation also suggests a possible inflammatory process, and psychosis is also. I have demonstrated that inflammation cooperates in that fibrosis process in a significant proportion of phosphorus monofluoride ILD cases. As a key point in treatment, it is important to stabilize the underlying disease. In cases of interstitial pneumonia with an inflammatory process, if fibrosis progresses despite treatment for the inflammatory conditions, the administration of antifibrotic drugs should be considered. So, the key point is to stabilize the underlying disease first. I present the risk factors for the progression of PF based on each underlying inflammatory condition, decreased. In function tests, 20% or greater fibrosis on CT and honeycombing lung formation were found to be predictive factors of progression. And if these are recognized, we should intensify treatment and give more immunosuppressive agents. Once again, we will discuss the treatment strategy for PF in diseases where an inflammatory process is suspected. It is necessary to treat the underlying disease, that is, the kind of treatment with immunosuppressive drugs such as steroids, GR, or MMF. This kind of biological agent is performed after this kind of immunosuppressive drug is administered. Consider if the fibrotic process has progressed, then consider antifibrotic agents such as pirfenidone and nintedanib, approved for IPF and other. Unclassifiable ILD, and is approved for CTD, chronic HP, NSIP, and IPF. This is a summary of antifibrotic drugs and immunosuppressive drugs. Antifibrotic drugs include pirfenidone and nintedanib. Nintedanib has evidence for IPF and phosphorus monofluoride ILD. So, pirfenidone has evidence for IPF, SSILD, and phosphorus monofluoride ILD, kind of. Autoimmune diseases, ILD. Immunosuppressive drugs include corticosteroids, which are often used initially along with sparing agents such as MMF, azathioprine, cyclophosphamide, and methotrexate for treatment-resistant CTD, drugs such as MMF. And inhibitors may also be used. Summary of immunosuppressive drugs used for interstitial pneumonia. Corticosteroids are used as anti-inflammatory drugs for interstitial pneumonia. Small molecule drugs such as mycophenolate, azathioprine, cyclophosphamide, and tacrolimus are used as steroid-sparing agents. Biological agents may also be considered for cases with insufficient therapeutic effects. We will now discuss immunosuppressive drugs for interstitial pneumonia in general. The following monitoring is performed during drug administration. Side effects of drugs include leukopenia, liver dysfunction, and kidney dysfunction, among others. For drugs such as tacrolimus and cyclosporin, drug plasma concentration may also be measured. In terms of infections, pneumocystis pneumonia requires particular attention in Asian regions. So, this is a list of monitoring points for patients receiving immunosuppressive drugs. Blood cells are monitored weekly in the initial stage of administration, so if it is stabilized, then every 2 or 3 months. Liver and kidney function is monitored monthly, and drug levels are monitored for certain inhibitors. Urinalysis is used to monitor for hemorrhagic cystitis associated with cyclophosphamide. Respiratory function tests are performed every 3 to 6 months, and chest imaging is performed every 6 to 12 months to assess fibrosis and respiratory status. However, in Japan, access to a CT scan is relatively good, so we can take the CT scan today or in 15 minutes, so imaging evaluations are often performed in a short time. So now let's move on to drugs. The administration of corticosteroids, high-dose corticosteroids, are generally not used for the treatment of interstitial pneumonia, but they may be administered in cases of LAPIT. LAPIT. LAPIT, progressive interstitial pneumonia positive for MDA5, or acute exacerbation of interstitial pneumonia, where a strong anti-inflammatory effect is anticipated. But although steroid administration is permitted in the treatment of SSC, high-dose steroid is not. Approved, not recommended due to renal crisis over 10 milligrams or so. For SSC-associated high risk of crisis, it is generally not administered. Risks associated with corticosteroids include infections, metabolic disorders such as osteoporosis and diabetes, and cardiovascular events. So we must check for them. In particular, regarding the risk of infection, it has been reported that after 2 to 3 years of corticosteroid administration, the risk of infection does not return to the level prior to administration. So, administration of corticosteroids, more shortly, is recommended. Therefore, it is important to avoid long-term administration of corticosteroids and use sparing agents in small doses. For short periods of time. This is for patients with interstitial pneumonia for whom corticosteroids are indicated. Generally, administration of corticosteroids for IPF is considered harmful and contraindicated. However, administration for acute interstitial pneumonia is occasionally performed, though the prognosis is poor when administration of treatment. Typically begins with a moderate dose of 0.5 to 1 milligram per kilogram, gradually reduced over months. In case therapy with 500 to 1,000 milligrams, they may be administered. Therapy is contraindicated for IPF, but it is used with other glucose system. But it is used in other conditions, such as collagen disease, ILD, and polymyositis. There are few randomized trials, with most studies being retrospective cohorts and case studies. In recent studies, mycophenolate and efficacy, it is more used. Mycophenolate is more used, studying doses 1 to 2 milligrams per kilogram per day, user starting at 500 milligrams per day and increasing to 1,000 to 1,500 mg per day. And let's move to cyclophosphamide. It is mainly used for SSC, or administration of 1 to 2 milligrams per kilogram per day. FVC was significantly improved in scleroderma studies, but MMF has higher tolerability and fewer adverse events, cyclophosphamide is less used by administration, but the rapidly fibrosing process of systemic sclerosis. Cyclophosphamide intravenous administration is also used. If using cyclophosphamide, an intravenous dose of 500 to 750 milligrams per square meter once a month is recommended. Mycophenolate is often used for SSc-ILD. It may be used in Europe and the United States, and has been used in a relative number of CTD-ILD cases. It is used for that kind of disease. It is not very effective for joint symptoms, while it is used for connective tissue disease, it is for long term condition relief, not used for arthralgia. In particular, SSc-ILD is considered to be highly treatable with cyclophosphamide used first, and MMF used as the first choice for SSc-ILD. Inhibitors such as tacrolimus and cyclophosphamide. Cyclosporin are mainly used in Japan due to their development history, and most reports are from Japan, they are often used as steroid-sparing treatment agents. It started with a dose of 1 to 3 milligrams per day, and the dose is adjusted while monitoring blood levels. 5 to 10 milligrams is the guideline for tacrolimus. The most difficult case is anti-MDA5 positive ILD. MDA5 skin symptoms are not prominent, and this progresses. Rapidly progressive interstitial pneumonia has a very high mortality rate. Treatment with a single drug is ineffective, but combining multiple drugs improves efficacy. In particular, therapeutic effects have been reported for high-dose methylprednisolone and intravenous cyclophosphamide. The therapeutic efficacy of JAK inhibitors has been reported in some cases, and for refractory cases, rituximab is used. Difficult to treat conditions. Methotrexate used for Methotrexate was previously avoided in patients with rheumatoid arthritis due to increasing risk of ILD, but recent studies suggest methotrexate administration is actually protective and inhibits the onset and progression of interstitial pneumonia. Starting dose is 6 mg per week, but in Europe and US it is 7.5 to 10 mg in Asian people, and is considered. So, high rate of gastrointestinal adverse effects. Titrate up 2 to 2.5 mg every few weeks. Final dose 8 to 12 mg. So folic acid administration is needed for preventing bone marrow suppression and stomatitis toxicity. Demonstrated in recent studies, even after adjusting for confounding factors, the incidence of interstitial pneumonia was lower in the methotrexate-treated group, and even when comparing multiple studies, a lower incidence of interstitial pneumonia was seen in the methotrexate-treated group. Biological agents, including IL-6 inhibitors and CD20 inhibitors, have recently been reported to be effective. These agents are also reported to improve FVC and stabilize the inflammatory process, and IL-6 inhibitor. Inhibited with reported efficacy in LAD and SSC, while the taximab is believed to improve inflammation by inhibiting CD20 and inducing the bell depression. But the question is necessary regarding the risk of infection with ISM CRP rebels and rebels may decrease, leading difficulty to assessing infections. JAK inhibitors have recently begun to be used for CTD-ILD. Their efficacy has been reported particularly in RAW-ID, ISSC-ILD. While some reports suggested that the risk of infection malignant tumor are not significant but reported in study so some no risk patients so in clinically used so we need are recognized too. Malignancy and infection. So through the pre-treatment treatment evaluation. Malign. CAT scan or lower. Endoscopy and an administration of a singles vaccines necessary. Additionally, thrombosis requires particular attention as a major advanced cardiovascular event. This is a take-home message, and as a conclusion, there is growing evidence for supporting the use of immunosuppressive drugs for the progression of fibrosis caused by inflammatory process. In CTD, consideration should be fast given to improving or intensifying treatment for inflammatory condition. Immunoregressive suppressive drugs are known to increase the risk of infection, and appropriate prevention and monitoring necessary. Thank you for very much for listening.